Welcome to 340B Insight from 340B Health.
Hello from Washington, D.C., and welcome back to 340B Insight, the podcast about the 340B drug pricing program. I'm your host, David Glendinning with 340B Health. Our guest today is 340B Health President and CEO Maureen Testoni. We speak with Maureen regularly and wanted to have her back on the show to give us a year-end wrap-up of all the developments in the 340B world. So here's that conversation. Today, we are speaking again with 340B Health President and CEO Maureen Testoni. Maureen, thank you for making the time to be with us, and welcome back to 340B Insight.
Thank you, David. I really appreciate the opportunity.
It is December now, believe it or not, and you were last on the show in late September. What has been happening in 340B since then?
I think the biggest issue in 340B has been a number of drugmaker proposals to turn 340B into a rebate. Other issues are that we're really focusing on are litigation around state contract pharmacy laws. There was also the first release of its kind by a state that had imposed certain reporting requirements on 340B hospitals. And that is something else that's new and I think important to understand.
Let's start with the rebates, as I know that's been such a big deal for the 340B community, and you just called it the number one concern at this point. Listeners of the show will know that Johnson & Johnson paused implementation of its rebate model after HRSA threatened strong enforcement actions. What is the latest on that issue?
Johnson & Johnson has now sued HRSA. They're essentially saying that HRSA does not have the authority to block a rebate model. And since then, we're also seeing three other manufacturers come out saying that they want to do a rebate proposal. Bristol Squibb and Lilly have also sued HRSA, saying that they don't have authority to stop a rebate model, and both manufacturers want to impose a rebate model. And then Sanofi announced that it was going to go forward and impose a rebate model effective January 6th. So we'll see if that goes forward there, but that is something that is obviously very concerning because of the short date.
And let's talk about some of the concerns that the 340B community has. What are some of those main concerns about 340B rebates when it comes to hospitals?
Well, sticking with Sanofi, Sanofi was very explicit about the rules that they're going to oppose before they would approve a 340B rebate for a drug. And it's very concerning because what Sanofi is saying is that we're going to impose our own rules as to which individuals 340B hospitals can deem to qualify for 340B. And the rules that they're imposing are, clearly intended to reduce the number of patients that hospitals can consider to be patients for 340B purposes. So this would essentially reduce the number of drugs that the company would have to offer a 340B discount on. Some of the things that they are doing is they are requiring that, patients have been seen at the covered entity within 2 years. That is a rule that does not exist anywhere under HRSA's compliance policies. They are requiring that the prescription be directly linked to the type of medical care, to an actual service that the individual has received at the covered entity. And yet we all know that, under 340B rules, there can be follow-up care, there can be referrals. HRSA does not make that tight a limit as to when 340B can be used. They have rules around hospitals only using prescribers that are employed by the hospital or have some other type of affiliation, which is really not spelled out what that affiliation would need to look like. They're requiring various types of patient encounter data to be able to make some of these determinations. And that is, just very concerning that they would, try to impose their own rules like this under a rebate program. And I think that's a big concern that hospitals have.
And I will mention that there's no public response to the Sanofi plan from HRSA yet, and no lawsuit from the company, though that's as of when we are speaking today. We know things can change quickly in this area. So that covers Sanofi. What do we know at this point about the other rebate models that drug makers are pushing?
We don't have a lot of details really on the other rebate models. We know that Johnson & Johnson plan to use the same vendor, Beacon, for processing its rebates. So they do have information on the types of claims, some of the claims data that they're looking for, but they don't really provide all the details as to how they're going to use that information to determine whether to approve a claim. They just say, we're going to get this data and we will, then determine whether to approve. But they're not really saying what you would have to show for sure to make sure that your claim would be approved. That's a distinction with Sanofi going into a lot more detail about the new rules that they are imposing. Similarly with Lilly and with Bristol Myers Squibb, we don't know exactly what the rules are that they are proposing. And that is obviously concerning for hospitals because now, if rebates were to go forward, it's all in the hands of the manufacturers as to whether and when you would receive the 340B discount that, you are supposed to be getting, that they're obligated to provide you under the 340B statute.
Why are drug companies saying they need to impose rebates on 340B hospitals? What reasons are they giving in all of these notices and lawsuits they've been filing?
Manufacturers have been claiming that 340B has grown, beyond what it is supposed to grow. So they are concerned about the fact that a high number of their drugs are being subject to 340B discounts than there were in 1992 when 340B was enacted. But the truth is, healthcare has moved from the inpatient setting in a hospital to the outpatient setting. So many more drugs are available in the outpatient setting than there were in 1992. And, we have, people aren't necessarily even getting certain heart surgeries anymore because they can rely on certain specialty drugs to address that. So it's not a surprise. They are also claiming that 340B covered entities are not always following the rules around 340B and that they believe, HRSA isn't doing a good job with that. And that's, you can see this with, especially with the types of rules that Sanofi is trying to put into place around, does the individual patient really qualify for 340B? But the truth is, the Sanofi is not going to be able to figure that out. This is something you have to look at medical charts. When HRSA goes in and audits covered entities, they are looking at the charts, at the patient charts to make that determination as to whether the hospitals are appropriately using 340B for the right kinds of patients. And in recent years, we're seeing findings in that area against hospitals to be very, very low. So there is just no evidence of widespread abuse by hospitals in the area of whether or not patients really qualify for 340B. And another issue that they bring up is something that's called a duplicate discount. It's a little confusing. It means that if an entity buys a drug at the 340B price, then the Medicaid agency should not be requesting a rebate from the manufacturer for that drug. And when you look at the findings from HRSA audits, there is nothing in any of those findings to suggest that there's widespread duplicate discounts going on, because the fact is HRSA does not check to see whether or not a state actually sought a rebate and whether or not the manufacturer actually paid it for a 340B drug. The only thing that HRSA does when they go into their audit is identify whether the hospital complied with duplicate discount requirements. And those requirements are that the hospital has to put its billing number up on HRSA's website, and that way states can use that billing number to exclude any of the drug claims that are for Medicaid patients. So hospitals, if they transpose, a couple of numbers in their, when they put it up on the website, they'll get a finding that says duplicate discounts. And in fact, many hospitals are able to get the duplicate discount finding changed to, a website error finding, because they're able to get their Medicaid agency to say, no, we don't even use HRSA's website. We have our own process for identifying 340B claims, and we can confirm we have not made any requests to the manufacturers for rebates on this entity's claims. So when we're seeing findings made by the government on duplicate discounts, it's really important to understand that does not in any way, shape, or form mean that a duplicate discount actually occurred. And we have not seen real data produced by these manufacturers to demonstrate that that this is actually a serious issue.
Our listeners will be eager to know where this whole rebate debate leads for them. So, what is 340B Health doing to advocate against these rebates?
One, now that it's in the federal courts, we will again be very involved with the litigation. In previous litigation that has been filed by manufacturers against the government, we have always submitted amicus briefs, sometimes on our own, sometimes we work with other associations. So we are currently in discussions with our legal counsel to determine the best way to interact in these cases, whether it is by actually intervening, which would, if we got permission to intervene, that would allow us to make arguments directly to the judge. So it gives us a little bit more of a presence than an amicus. However, I will mention this is likely to take a while. This is unlikely to be a fast-moving lawsuit. So there is, there still is some time before the court is really going to require any briefing on this case. I will also mention that the IRA, the legislation about that includes provisions to allow Medicare to negotiate lower prices for drug, is going to be implemented in the coming year, and manufacturers are going to be submitting within a few months their plans for implementing how they're going to make the Medicare prices available. And it's been controversial as to how 340B is going to fit into that. Covered entities are entitled to the 340B price regardless of what the Medicare price is, but the process that the government is using to implement it does conflict with 340B in some ways. It is absolutely doable to do what the government is proposing, but the manufacturers believe that it is having a rebate program would make it easier for them to comply with the government's process. So I think it's important that we have a lot of advocacy going on about the fact that this is not needed. Rebates are not needed for the IRA as well. I wrote about this in a Wall Street Journal essay recently. The IRA was never intended to transform 340B into a rebate system. The government has refused to require 340B rebates either for the Medicare program, the drugs that are subject to the negotiation, or otherwise for 340B drugs. And drugmakers absolutely have other avenues to comply with the IRA and 340B, which the Centers for Medicare and Medicaid Services is saying that they are exploring as well. So it's important that we are, advocating against rebates for 340B, but also in the context of the Medicare negotiation scheme.
At the top of the show, you mentioned the contract pharmacy litigation over state laws. What is the latest status on those?
So far, we have seen a number of lawsuits from manufacturers and from their association, Pharma, and a lot of those were arguing that, the states just do not have the authority to make any rules around 340B because 340B is a federal law. And so far, though, they have lost those. So that has been great. However, there are some manufacturers are making new arguments around very technical issues about whether the providers retain title when the drugs are transferred to the contract pharmacy and some other issues. We are very involved in these cases. We do amicus briefs for all of these lawsuits, along with a couple of others of the hospital associations and state associations. But we are also working closely with some of the attorneys that are working on some of these cases to assist with the more technical analysis about this, whether there's any merit to some of these arguments that the manufacturers are making. I do not believe there is. But that is the case that we are really building up right now, and that I expect to be the big issue in the coming year.
You also said there's a new 340B report out, and our regular listeners will know that is coming from Minnesota, the land of 10,000 lakes. What does that report say?
So this Minnesota report, it comes out of legislation that was passed in 2023 that requires covered entities to submit certain information to the state. And one of the things that they required is that covered entities report the prices, they're spending on 340B drugs, and then how much they received from insurers, in payment for those drugs. And that number, the number that they released was 630 million. Now, that is a calculation that we are really take issue with, because it really overstates the value of 340B. 630 million is not the value of 340B for the hospitals in Minnesota. The value is going to be lower than that. And that's because all that 340B does is it gives a discount on the drug. But hospitals that aren't in 340B don't buy the drug at the sticker price, at this, it's called wholesale acquisition cost, which is like the car sticker price. Nobody buys it at that. And so if they weren't in 340B, they would still be getting discounts on drugs by purchasing through their group purchasing organization. So the 630 millions is a number that may apply if everybody was purchasing their drugs at whack, and the only people that got a discount was 340B. So what you really want to do, if you were trying to see what the benefit of 340B is you would compare the GPO prices that hospitals have against what they're paying for 340B. So if the 340B price is 80, the GPO price is 100, and the sticker price, the WAC price, is 200, then the real difference isn't going to be between that $80 and the 200. It's going to be between the $80 for 340B and the 100 for the GPO. But even looking at that 630 number, it's important to understand what that number means in terms of how much is spent on patient care by Minnesota hospitals overall. And that is $15 billion on patient care last year. And about $770 million was spent on uncompensated, unreimbursed care. So that is care where the hospital received no compensation, people that just did not have insurance, or care where they received, less than their costs, such as, Medicaid, which notoriously pays much less than the cost of care. And then if you were to add to that number the underpayment that hospitals receive from Medicare, I personally believe that number would be closer to $1 billion. And so without 340B, it'd be very difficult for hospitals to maintain that level of care.
If it's the end of the year, we here at 340B Health are preparing for the upcoming 340B Coalition Winter Conference. What are you most looking forward to for that meeting?
I really love our conferences. It's just such a great, so many 340B minds in one place it is really fun for me. And, this year our conference will be in San Diego. It'll be in February 24th to the 26th. I really encourage everybody who is really interested in 340B to attend. We do a lot of sessions on compliance issues, including the Inflation Reduction Act, the Medicare negotiation policy that I talked about earlier, sessions on optimizing 340B, on how to stay compliant on 340B. We will have sessions to sort of what to expect in Washington with the new administration and the new Congress. And our featured speaker will be a Harvard professor that's going to be discussing the future of healthcare economics. So it's a great way to network with other 340B people. It's a great way to learn new strategies that your peers may be using around 340B, sharing best practices learning new ideas, talking about 340B advocacy. Early bird registration is going on right now, and it's going to end December 20th. So I really encourage people to sign up before then so you can secure your discounted rate.
And we will be sure to put that link and a few other links of interest in the show notes so our listeners don't need to venture far to find them. Maureen, thank you for taking the time during the pre-holiday rush to be with us today. We all appreciate it.
Well, thank you so much for having me. I really appreciate it, David.
We thank Maureen Testoni again for being with us today and all year long. And we thank you, our loyal listeners, for joining us during this season of 340B Insight. This is our last episode of 2024, and we will be taking a short break while we prepare for another full season of episodes in 2025. Please keep those ideas coming for episodes and guests. You can always email us at podcast@340bhealth.org. Have a joyous, peaceful holiday season and a happy, healthy new year. We will be back in January. In the meantime, as always, thanks for listening and be well.
Thanks for listening to 340B Insight. Subscribe and rate us on Apple Podcasts, Google Play, Spotify, or wherever you listen to podcasts. For more information, visit our website at 340bpodcast.org. You can also follow us on Twitter at 340bhealth and submit a question or idea to the show by emailing us at podcast@340bhealth.org.
Topica.